Hello, my name is Sterling Henderson, and I'm presenting on an inner ear disorder. The patient that I was working with was an 84-year-old retired male being referred for possible BPPV. This is August 12th. He reported dizziness and nausea that was provoked with movement, and the symptoms came on August 8th. His symptoms were kind of episodic in nature, which produced nausea and dizziness through active daily living, such as laying down, turning over in bed, transferring from bed to standing during walking, and head movements in general. The patient also indicated that he had hearing loss, and it was greater in his left ear versus his right ear. For his plan, here is the structures that may be referring to the area. I'll let you go and just take it some time. You can pause this and look at that if you like. For my early hypothesis, I expected this patient most likely has a peripheral disorder, however, also considering other conditions of central disorder, neuromuscular, cervical dizziness, Meniere's disease, and orthostatic hypertension. Aggravating factors for him was rolling over, especially when he's rolling over to his right side, laying down, and specifically on his right side would be the most dizzy, provocative. And when he's laying down or when sitting up, either positioning was very dizzy for him, and when turning his head quickly. To ease this factor, or just more so limiting his dizziness, would be for him to just do the movement slowly, or to lay down but not fully straight back but on a recliner, not rolling over in bed and holding his head straight during ambulation. Okay, now looking at the patient's history, over a 24-hour period of time, there was really no changes for time of day, more so for type of activity. So at night when he was sleeping, he'd wake up, he'd be really dizzy from turning over. Or when he's moving around in the day, walking, turning his head, he's dizzy. Sitting down, trying to get up again, he's dizzy. So these symptoms beginning about 11 days before, and the mechanism of this kind of injury or onset was produced after having a nap. And he's getting up out of his nap, and he's really dizzy. And he's not really sure what's going on here. His family is worried. They rush him to the hospital, and he gives him meclizine. As you can see down here in previous treatment, they do a meclizine for him. They kind of see, okay, BPPV, and they send him home, which is kind of weird why you would treat. Before these current symptoms he is having, his prior history, he had no signs of dizziness, no previous episodes of this nausea. He didn't have any visual changes with this symptom either, nor did he have any prior history of headaches. The patient didn't have any red flags that stood out to me, nor any yellow flags. When he had the symptom come on, they rushed him to the hospital, where he had the CAT scanning and EKG, clearing out some of the strokes, the heart attacks, and the hemorrhages seemed to be all cleared through their testing. As for the medication, the patient was sent home with the meclizine, where he took it home, used it, and showed no benefit in using it. As for asterisk signs, I would want to measure, would include his dizziness. When he's rising out of bed, he would get a 3 out of 5 dizziness. During ambulation, as you would turn to the side and walking, he would get that dizziness, a 3 out of 5. And another subjective sign would be from when he was laying down and rolling over to his right side, as he indicated was the most dizziness that he would experience, which would be a 5 out of 5. So my hypothesis for this disorder this time would be a vestibular, just considering the time frame of how long it is provoked. Also, though, with the head movements and perhaps with eye movement, considering I also would like to include the hypofunctions. A central disorder, again, similar factors can be related to that with the eye movement, head movement. Cervical musculoskeletal for sure, just with that neck moving, could be provoking that dizziness either when turning in bed or when looking to the side. Visual deficits, perhaps he does have a visual problem that he is not aware of, that oculomotor problem for causing him to be dizzy. At this time, I did not include Meniere's disease, and I felt that because the episodes were much longer, plus that they were more so episodes, whereas Meniere's is more of a sudden onset, and they lasted up to an hour, whereas this symptom usually didn't last longer than a minute. So I took that out of the hypothesis. For clinical reasoning, looking at the severity of the condition, I would believe it is a severe condition, rank it as severe, just based off from the intensity of the symptoms that are provoked with movements that can be coming on throughout the night, during rest. It can greatly limit the patient's active daily living. Also, the irritability I considered as severe just because it is so limiting, so easily provoked just by doing transferring from laying down to standing up, walking around, moving his head, and being able to be so easily provoked with picking things up, just overall very irritable. The nature of the symptoms is vestibular, and the stages are acute to subacute. And as for the current stability of the disorder, I believe it is it's worsening a bit just because it has been increasing. The time before I saw him, just within 2 days, it says it had increased, and I was able to reproduce his symptoms quite easily with aspirin. So the plan for this patient is to assess using my hypothesis and looking at ocular motor exam, using smooth pursuit, the saccades, then also looking at gaze stability disorder using the DVA. Postural stability would be for assessing with a modified CAT-SIB, and in looking at the loose otolith or considering repositioning crystals, it would be assessed with the head roll or a Dix-Hallpike. For now, I deferred using the head shake just because that is one of the main causing factors for his dizziness, so I would like to, for now, pass that and assess it perhaps at next time. In the physical exam, I kept in mind that the patient had a postural disorder. He had that excessive kyphosis, the forward head round his shoulder. Something to consider, maybe how it might be related to a vestibular symptom. Also, when performing the smooth pursuit, the patient had a corrective tracking, especially when going to the right side and especially when at the end range. The saccades produced 2 corrective for locating the target, but not significant, I felt, at this time, just because of the age he is and the symptoms that often come on with the older patients. DVA, I used a modified Snellen chart that I was able to print off the internet, where it has about 6 lines, but it has been shown pretty beneficial, especially when you use a larger image of letters and a smaller. Anyways, in using that, the patient was able to follow 4 out of 5 lines, which I felt was pretty good, and nothing to be concerned there. For the head roll now, in moving the patient back into that position, I was able to provoke a 4 out of 5 dizziness when going to the right side, and a 5 out of 5 dizziness when going to the left side, and was able to reproduce an agiotropic nystagma bilaterally with an increase of speed of the beating when we roll them over to the left side. There's a video I want you to see, and just so you can envision and see what I'm looking at, I will be playing next, and I want you to look for the beating.
Yep, straight back. There you go.
Oh, something's changing. My head's changing, I tell you.
Keep your eyes open. Open your eyes. There you go. Good.
Got some movement,
Yeah.
Don't seem too bad, though.
Let's go on the right side. Yep, we're just going to tilt our head back on the right side, right? Okay. Now hold on for just a minute there. We're going to rotate your head and look over to the left side, okay?
Okay.
How you doing?
Doing something a little bit.
Yeah. Well,
I say my head's a little wobbly.
Yeah, it's alright. We'll just hang out there for a minute.
Oh, there's something spinning around.
It's alright. We'll just hang out there for just a minute.
Yeah, feel like this whole thing.
My primary hypothesis following my physical exam would be that he has an increase, with looking at the increased dizziness when rolling to his left side and the severity of the left side agiotropic nystagma beating. My hypothesis was that he had a cupulolithiasis, left horizontal canal, and possibly a contributing factors could be the central disorder, just with identifying the smooth pursue and seeing that that corrective jumping. As for my asterisk signs, I want to, in using to help me decide on this, well, the symptoms lasted, well, mostly under a minute, and they were provoked with movement, which really is episodic, like you would expect from this kind of condition. The time frame is accurate, and the exam is very beneficial, and in most cases able to identify. For my plan of care in this patient, I do expect this patient to be able to get full recovery, and time frame will be anywhere between 1 to 3 weeks. This will be much 2 times a week, 3 to 4 appointments. Considering it will be a little bit longer than usual for just BPPV because it is a cupulolithiasis symptom, indicating it may require time for it to get loose from the crystals. So it could even be longer than 3 weeks. But that's my goal. He also showed some hypofunctions, and you were able to see that through the smooth pursue. So that is also something to keep in the back of the mind, considering time to recovery. As for his goals, in 3 weeks I expect this patient to be able to walk again, to be able to move around without dizziness. I also expect that this patient will be able to bend down, tie his shoes in 3 weeks without dizziness. He would also be able to lay down and roll over. I said a little bit backwards, but that's the first one. Be able to lay down, roll over without having provocative of dizziness. I expect this patient, if he doesn't improve within 3 weeks, I'm going to consider referring this patient to someone else where he can get better help, someone who is more experienced with vestibular conditions. My overall management of this patient is going to be including canal repositioning procedure. Also, another part that would be important in treating this patient would be to consider central treatment or central disorders. In this smooth pursuit, that's one of the indications for it, is looking at that that corrective eye jerks as you're following the eye. He had it to the right. So again, if he's still having symptoms after I have been able to perform some correctional canal repositioning, that would be the next step to look at in treating.